Hello and welcome to this lecture about the taking of the musculoskeletal system history. I know you guys studied the musculoskeletal system last semester, and hopefully that'll make this lecture a lot more valuable to you as you think through how you're going to use history taking and consultation skills to help your patients. We always want to start when we talk about the history. Why? Why are we covering this? Why have we included this as part of your curriculum? And you guys know, you've heard me enough now to know that always I start with God. God made human beings, therefore human beings are important. Therefore, we as doctors have to take good care of human beings. God loves them. He loves you too. But we have a high responsibility to take care of them. We always want to remember that when we enter these patient rooms and talk to people. And, this system generates a ton of visits to doctors, back pain, knee pain, just joint pain in general, all generate a number of visits to doctors every year. It's always in the top 10 or top 5 of reasons people come to the doctor. So it's a really important history skill to master. And how are we going to do it? You guys know Socrates or Socrates. We always want to remind you guys, this is a tool. It doesn't give you the whole history. And you can't use all of it in every circumstance. But it does apply to pain really, really well. And some of the other complaints you'll encounter in the musculoskeletal history, like stiffness, swelling, these kind of things. So it's good to use. Just remember, it's not everything. You still have to think through carefully what questions you want to answer. But you start open with your questions and let the patient talk as much as they will about their condition. And then you use Socrates to further define the rest of the picture by using it as more of a closed-ended questioning tool to get through the rest of the details you need about their problem. So you have to ask about other things beyond just pain and other things associated with it. So you have to go beyond Socrates. I think I wrote Socrates plus somewhere in the lecture here, but you always, always, always want to ask about function when the musculoskeletal history is being discussed, because it's not just about what they feel, but how it's affecting their lives. And the other thing you want to make sure you do is get a thorough history of what's going on with the other systems in their body, because the musculoskeletal system has problems that are frequently related to other things going on in other systems in the body. So those two things. So the review of systems becomes really, really important there, to go through the other systems and see what else is going on with the musculoskeletal system problem. All right, obviously, you're going to use your good consultation skills. You guys know those pretty well. I'm not going to go through them all, but they all apply, from starting with open-ended questions to using active listening to setting up the room correctly to signposting and summarizing and all these things, clarifying. You really want to keep in mind that often these people have suffered greatly. Certainly that's true of many chronic pain conditions, but even if it's an acute thing that's only gone on for a few days, how painful and life-changing for a few days and a few weeks is a broken leg or a broken arm. How bad is it when you've developed rheumatoid arthritis and had weeks of joint swelling and pain? So remember, they've suffered greatly, and one of the most important things you can do for them is to listen. That's good therapy. They always feel better once they've been heard about what's going on with them, because that gives them some hope that you are interested and perhaps you have some solutions for them. All right, so that's how we're going to do it. So what are we going to do? We're going to start with Socrates. We're going to go through it and use this as our point of departure for talking about the system history. So sight comes first, as you guys know, the S in Socrates. So you always want to ask, not just where in the body, but what tissues are generating the pain. It could be joints, which is often what we think about, or I think about when I think about the MSK history, but it could also be the muscles themselves, could be the tendons, the ligaments, other soft tissues, could be the joint lining, like the synovium, all of these things, the tendon sheath around the tendon. So try to think about, as they're giving you the history, what might be causing this sort of pain? Is it one spot or an area? In other words, can they touch it with one finger like you can often do with a fracture, where there's point tenderness? Or is it a whole area it's a more diffuse type of pain in an area? Is it many areas? And then if there are many, how many? And how are they characterized? So, is it 2? Is it 4? Is it 5? Is it 1? So that's where I put these terms: monoarthritis, which means inflammation of one joint; oligoarthritis, which is 2 to 4 joints; and then polyarthritis, which is more than 4 joints. So you really do want to remember those terms, but the idea is it's really important to know how many parts of the body are involved. Not just joints, could be anything where you want to ask about how many parts of the body are involved. We'll get into chronic pain syndrome, fibromyalgia later. So how many areas, and how are they characterized? Are they small joints, large joints? Are they, when I say small joints, I mean like the hands, the wrist, the feet. Are they large joints? The shoulder, the knee, the hip, this kind of thing. Are they parts of the musculoskeletal system, like the muscles on the axial skeleton? So, the shoulders and chest area, upper back. Are they peripheral system? Are they out on the arms, the legs, these kind of things? So think about how many areas and how they're characterized. And, are there other symptoms at the site? So not just pain, but do they show any of the cardinal signs of inflammation? By which I mean rubor, calor, we already talked about dolor, that's pain, and tumor, swelling. So do they have redness, swelling, heat, or warmth at that spot in addition to pain? That would indicate an inflammatory or an infectious condition. Is it just pain? It's far more common, honestly, to get pain in the musculoskeletal system and joints particularly than it is to actually have inflammation of the joint. If you take a bunch of people with knee pain, even if they have swelling in their knee, if it's not warm and red, and you put a needle into it and take that fluid out, it is not inflammatory fluid most of the time. So arthralgia, pain in the joint, is far more common than arthritis. And that's something to think about in terms of how you treat people. It's not always an inflammatory problem. And then that's sort of what this arthralgia versus arthritis comment there is designed to remind me to say. Just think about, again, where is this pain coming from on the body? What tissues is it coming from? How many spots is it? And what part of the body is that? Again, axial, peripheral, large joints, small joints, that kind of thing. So work your way through those things as far as the site, as the patient's telling you the story. Be thinking about how to classify things. Because we're always talking about, at least I am, always talking about, the purpose of gathering the history and these facts is to begin constructing a differential diagnosis, right? A diagnostic hypothesis. So I have a few images here we'll go through quickly. These are from McLeod's, which of course is a great resource if you want to review things or if anything's not clear from things I'm saying. But you want to think, what is going on with the body that's causing this problem? So, we talk about arthralgia. You can have infection. You can have a post-infectious process like a post-streptococcal synovitis, or even, rheumatic fever, of course. Reactive arthritis from a sexually transmitted illness. It could be degenerative. Just people are elderly and they've used their joints their whole life and they're wearing down. Certainly you want to think about things like neoplastic processes, like a tumor of the bone or the muscle or something like that. Crystal formation, which is more of a metabolic problem, I suppose. Gout or pseudo-gout or any of these types of processes can cause a lot of pain and suffering in the musculoskeletal system. Trauma, of course, probably one of the main reasons that you get presented with musculoskeletal complaints is trauma. And certainly in those cases, you want the patient to tell you everything about the event that happened. If it was a car, how fast was the car going? Where did it get hit? In other words, what forces were applied to them? when they were struck by the other vehicle. If it's a fall from how high and onto what? All of these kind of things are really important to ask and get a thorough event history from the patient. But anyway, construct your differential diagnosis. And how does the history of the site help you here? Well, these drawings of rheumatoid arthritis, psoriatic arthritis, inflammatory spondylitis, which is probably my favorite medical term of all time, is seronegative spondyloarthropathy. And so that's what this would represent. There are a few of them that we'll worry about, and then osteoarthritis. So when you get a history of which sites are involved, you can kind of characterize them. Is this characteristic of psoriatic arthritis, rheumatoid arthritis, spondylitis, so things like ankylosing spondylitis, inflammatory bowel disease associated arthritis, or osteoarthritis. And so you do want to think. So rheumatoid arthritis, obviously you have the small joints, but also you have the shoulders, the neck, the knees and hips. Whereas psoriatic arthritis, you're looking really at the peripheral skeleton and small joints, but to include the elbow. And obviously the inflammatory spondylitis primarily affects the central skeleton, the axial skeleton. You're looking at the spine and the hips and the shoulders, the large joints nearer the core of the body. And then osteoarthritis does tend to be in high use joints and peripheral joints because, we use those the most. We use our feet and hands the most of any joint, followed by the knees and hips for sure as far as walking. So think about how the site fits into a pattern of what could be going on with this patient, and be thinking about all these different possibilities as far as the diagnostic hypothesis goes. Think in categories and try to narrow things down as you go through the history. So let's go to onset, the O in Socrates or Socrates. Was it acute? Things like trauma or gout. In the case of trauma, it will typically be pretty obvious, what caused the pain. The question will be is how bad is the injury and what treatment needs to be applied. So trauma is a good one to really clearly define the onset. Again, get a good event history from them. Gout tends to come on pretty suddenly and be very painful. And these people often have a history of gout to help you, and it tends to occur in characteristic areas. So if you're talking about somebody with their first metatarsophalangeal joint, their first MTP joint that's big, red, warm, and swollen and painful, they even say they don't want to lay a bed sheet on it when they get into their bed at night. It's so painful. That's when you think gout. Usually lasts for a few days and then will resolve, but resolves faster if you give them anti-inflammatory drugs. Is it chronic? And by chronic we mean months, so longer than 3 months you can think about. We think about inflammatory conditions. Things like the patient who presents to you with their first bout of rheumatoid arthritis will have had symptoms for months by the time they come to you, typically. And longer than months, you can even think years in this case, chronic pain syndrome or fibromyalgia as it's often called, go on for years. I mean, the characteristic thing there is it's just pain. There's no physical deformity. There's no other cardinal sign of inflammation. It's just pain in specific spots. I have an image there of the specific spots where they typically have pain. These are so-called trigger points. If you touch these, you really do elicit the pain that they're feeling all the time. And it can be a tough one to deal with, but it's good to get a good history. They feel, again, listened to is really important for them, that they've suffered a lot and they want somebody to listen to them. This is the equivalent in Arabic would be my favorite complaint here, I think, when you ask, shusar or shubteshki, people say, fi wajah, fi kul jasmi. My whole body is hurting. And that's kind of what these fibromyalgia patients are like. You just have to listen to them. You want to get a good history. That's one of the most therapeutic things you can do. Okay, going on to an infected joint. This typically develops over days, not hours, not suddenly, and not months, but it comes on to people gradually over a few days and can get quite severe and painful for sure. And very dangerous. Has to get immediate therapy. All right, moving on to the character of the pain. So just a few examples. This isn't meant to be exhaustive or to cover everything, but bone pain tends to be penetrating and deep. So it's like it is sort of sharp, but it's deep. Feels like it's in the bones, literally. And it's characterized by being worse at night. Certainly another number of bony tumors tend to bother people more at night for whatever reason. Muscle pain will often be described as stiffness or soreness. It also tends to be deep, and it could be from trauma, of course, or an inflammatory condition, but that is often, what you'll get from them. Fracture pain is sharp, stabbing, and it's usually really well localized because it hurts over where the bone is broken. And then nerve impingement pain is the pain they'll describe as shooting. Is this technically the musculoskeletal system? No, but often the reason the nerve is impinged is because of arthritis or something like that, and so you get sciatica more commonly when you have some arthritis of the lower spine, and the nerve impingement occurs. So it's a musculoskeletal problem generating a neurologic complaint. So you want to think about shooting pain as more characteristic of nerve pain affiliated with the musculoskeletal system. All right. So diving into the rest of Socrates, radiation. So, it can really fool you in the musculoskeletal system. A good example is the 11-year-old obese patient who comes to you with knee pain, and they're limping. And you think, oh, wow, I wonder what they did to their knee. Well, in some cases, that pain is from what's called a slipped capital femoral epiphysis, SCFE or SCFE. And it's a joint problem that is in the hip. But that pain is referred to their knee, and so it can be a little tricky, to figure out. But here's the table from McLeod's about all of the places where pain radiates. You have C1, C2 pain that radiates to the occiput, C3, C4 pain in the neck that goes to the interscapular region, so between the shoulders, et cetera, et cetera. I already mentioned, the hip going to the anterior thigh or knee. The knee, of course, can radiate to the thigh or the hip, and so you do want to always consider the joint above and the joint below when you're getting a history from people. You want to examine a joint above and a joint below if they're complaining of pain in a specific area, just to see if it's referred from one joint to the other. And the other big one, of course, is the spine, where pain radiates to the buttocks, pain radiates down the leg. That's a really common one you will encounter, but one we more classically think of, so I don't think you'll be fooled as easily by that one. Radiation is different than migration. So sometimes I'll ask about radiation in English to a patient, oh, do you have pain that's moving anywhere? Well, that could be radiation, but it could also be migration. People get migratory arthritis, or palindromic rheumatism is one of the ones that people get, where the pain will move from joint to joint because inflammation is moving from joint to joint. So do define exactly what's going on with that pain in multiple areas that tends to occur in different areas at different times. All right, alleviating factors. Of course, you want to know what makes it better. So is it rest and support? That goes along with, traumatic injuries, muscle pain, fracture pain. You do want to know what medications they've taken. Sometimes people take too much of the medication, or that's it's not good for them. Sometimes the medication isn't working, but you do want to know what they've tried and what they've taken most recently so that you can adjust for that as you give them therapy. Or perhaps nothing makes it better. And this is true of things like infection, where it's just bad, severe, all the time, and nothing really is making it better. Those are the things to think through there. And again, you notice when I'm giving you these history points, I'm giving you things that point to one system or another, or one tissue or another. That's what you want to be doing, is thinking, oh, that sounds like muscle. Let me ask more about things affiliated with muscle pain. Oh, that sounds like the joint. Let me ask more about the joint. Is it gout? Is it infection? If it's one joint inflamed, you got to think about a few different things, but only a few things, like gout, like infection. What's more likely in that circumstance? So again, use all of this data to be forming a picture in your mind of what's most likely. Where does this story fit best? Does it fit with an infection? Does it fit best with trauma? Does it fit best with tumor or degeneration of the musculoskeletal system? So, associated symptoms. This is super important, like I mentioned. So, alleviating factors. The A in Socrates, we always think about alleviating and aggravating factors, but you really do want to think about associated symptoms with that A, because it will keep you from missing things with the MSK history. So, I talked a little bit about stiffness earlier, but let's talk about it again. What does the patient mean by stiffness? They could be talking about a few different things. You want to define clearly what they mean. Does it mean that they have reduced range of motion? And that can definitely happen with musculoskeletal problems, with inflammatory arthritis, with mechanical injury, all of these kind of things. But reduced range of motion. Is it a normal range of motion? In other words, they feel stiff, but they can do the whole range of motion. It's just difficult for them. Is that what they mean? Or is it just pain that makes them not want to move the joint, but in truth, their range of motion is totally fine? Try to define that with the patient, and you may have to do that on exam to a degree. The timing of the stiffness, how quickly is it resolved? This really triggers for us when we talk about stiffness in the morning. We always think about rheumatoid arthritis. The truth is a lot of people are stiff in the morning. I'm 43 years old. I'm stiff in the morning. But the difference with rheumatoid arthritis is it takes about a half hour or more to loosen up for them, to get moving, whereas it doesn't take most people nearly that long to get moving if it's just old age or osteoarthritis, those kind of things. So ask about when they get the stiffness and how quickly it resolves. And you can go through the Socrates questions for stiffness, of course, or ask about stiffness as you're going through the Socrates questions in association with pain or anything else they're experiencing. And then, these extra-articular features. So what's going on beyond the musculoskeletal system if we have a problem with the MSK system? Is it related to a general condition that's affecting the musculoskeletal system as well as other tissues, or is it isolated to the joints, bones, muscles, connective tissues? So always, again, I kind of start head to toe when I think through these, and first thing I think of is the whole body before I get to the head, and I think, gosh, are they losing weight? Are they having fever? And if they're having fever, really try to define when are they getting fever? What's the pattern? Rheumatoid arthritis or Still's disease or, these kind of things can give you fevers, and they occur periodically. It's not constant. It's not like an infection where you have it all the time for a couple of days and then it goes away. It's coming and going at specific intervals. And you want to get from the patient. You don't have to know all of those things now, what is associated with what. You may remember some from last semester, but you do want to get from the patient what is actually going on. You can always go look up the patterns, but you want to get the data on what they're experiencing first. Malaise, which anybody with inflammation or pain is going to feel run down and tired and fatigued, but it's worse when it's an inflammatory condition like lupus, rheumatoid arthritis, Sjogren's syndrome, these kind of things. Is there a rash? So again, whole body, skin. If there is a rash, what's the distribution of it? Because certain conditions are associated with certain distribution of rash, whether it's dermatomyositis, whether it's lupus. And a key thing to ask about is the rash photosensitive? In other words, do they have this butterfly rash, this malar rash with lupus that is worse when they're out in the sun? Photosensitive rash is helpful for defining an inflammatory process. And then you go through the rest of the body. I think about the head, I think about the sicca symptoms. So they have dry eyes, dry mouth, this kind of thing, where it's associated with a lot of different rheumatologic diseases. Mouth ulcers, goes along with a lot of inflammatory conditions. Could be lupus, could be Crohn's disease that's then giving you an arthritis related to the inflammatory condition of Crohn's disease. And moving down the body, Raynaud's, do they get the blue painful fingers when they get around cold air that resolve when they warm up? That's definitely, you can just have Raynaud's by itself. You go to take something out of the freezer at the grocery store and your hands get really blue and painful, and then they turn bright red and really hot for a short stretch as your body reperfuses them, and they go back to normal. That happens, and sometimes it's not associated with anything. It just happens. But often it can be associated with things like lupus, rheumatoid arthritis, other inflammatory conditions. And then the GI tract. A lot of the stuff does affect the GI tract. And I didn't mention everything. I mean, skin, there could be ulcers on the skin. The eyesight could be affected in rheumatoid arthritis, for example. But breathing could be affected. I don't think I put that in here, but you can get rheumatic or rheumatoid lung. You can get a pericarditis that's constricting your heart in lupus that gives you tamponade symptoms and dyspnea and chest pain from it. So ask about all of these things. Just go through each system. Just okay, anything with the head or neck? No. Anything with the heart or lungs? Chest pain, difficulty breathing. Anything with the GI system, difficulty swallowing. So things like dysphagia, abdominal pain, diarrhea, bloody stool. Well, why would that be affecting the musculoskeletal system? Again, people can get these spondyloarthropathies, these seronegative, which means they don't have a rheumatoid factor and the central skeleton is inflamed. They get sometimes this bad inflammatory arthritis associated with inflammatory bowel disease like Crohn's disease or ulcerative colitis. And so that GI history will help you see that they have the inflammatory bowel disease, which then gives you a clue that their musculoskeletal problem is from that. A good example of this, I had a guy come to me with joint pain, and as I was examining his joints, I noticed he had a few really characteristic findings like dactylitis, we call them sausage digits, where the fingers get really, really swollen, the toes get really, really swollen. But one thing I knew from his history, because I'd seen him before and I saw evidence of it in that visit, was he had psoriasis. He had plaques of psoriasis on his hands and feet and elbows and knees. And that really clued me in that what I was looking at was a case of psoriatic arthritis. So it helped me define, what was going on in the other system. The skin particularly helped me define what was going on with the musculoskeletal system. So really, really get a good review of systems as you go through the musculoskeletal history. And why? Why? Because look at all these arrows everywhere. I'm not going to read them all. This picture's in McLeod's. But as you see, every part of the body could be involved in some way with problems occurring in the musculoskeletal system. So I'm not going to go through all those. I just mentioned a lot in the last few minutes. So we'll just leave it there. But go back and look at McLeod's and read through that list and just see all of the ways that the whole body can be affected. And what characteristic features? I mean, we covered several of them. I talked about psoriatic arthritis just now, which is there. Talked about septic arthritis a little bit earlier, but just in general, we'll go through a couple of these. Gout. You can get kidney problems from the gout, or you may uncover they have a problem with alcohol use, because one of the things that will exacerbate gout is alcohol use. Septic arthritis, of course, fever and malaise, and that septic arthritis could be from an infection somewhere else. Maybe they've got a Streptococcus pneumoniae pneumonia, and they got bacteria in the bloodstream, and that seeded the joint with bacteria, so they end up with a septic arthritis, an infected joint. So think about the source of infection with those things. Maybe they have symptoms somewhere else. Reactive arthritis, urethritis, so they get pain when they urinate, inflammatory material in the urine. They get mouth and genital ulcers. They have conjunctivitis and iritis in the eyes. And then they get to inflammation of the tendon insertions, this enthesopathy, so Achilles tendinopathy, plantar fasciitis, and then sometimes a rash with it. So you see that constellation of things as you get a full system history of multiple body systems, the mouth ulcers, the eye problem, the rash, and then the joint makes you think of reactive arthritis. These kind of things. I guess rheumatoid arthritis is kind of an important one. They can get rheumatoid nodules under the skin. They can have eye troubles, episcleritis, dry eyes, that so-called Sicca syndromes I just mentioned. But again, the lung thing, they can get pulmonary fibrosis, pleural effusion. Some of them will get vasculitis, and so that will be presenting with kidney problems, eye problems, that kind of stuff. Splenomegaly and Raynaud's phenomenon are things that occur for sure. Sjogren's syndrome, dry eyes, so the keratoconjunctivitis sicca, but just that, all that means is dry eyes. Dry mouth, xerostomia, reduced or absent saliva. And then they will also get some enlargement of the salivary glands because of the inflammation, and they can also have Raynaud's phenomenon. And they may have those symptoms associated with other conditions like lupus or rheumatoid arthritis. With lupus, boy, it's a tough one. It affects all the tissues. It's really hard to diagnose unless they have a lot of the features of it. But they get that photosensitive rash I talked about earlier, especially on the face. They can definitely have ulcers in the mouth. They can get hair loss with it, and certainly whole body inflammatory symptoms like fever happen. Serositis, so I mentioned the pericardial effusion, but any serous tissue, say the peritoneum in the abdomen can be inflamed. The pericardium, the pleural lining can all be affected with inflammation and give you effusion and pain. And the key to treating those is treating the underlying disease. And then juvenile idiopathic arthritis, used to be called juvenile rheumatoid arthritis. Similar to rheumatoid arthritis symptoms, but not the same process. And it happens in younger people for the most part. But you think about rash, fever, hepatomegaly, splenomegaly, in addition to their joint pain. Okay, that's a lot. I'm going through those just really to emphasize strongly, one, how the history leads to diagnosis. If you get a pattern like one of these, it makes diagnosis much easier, or at least you can narrow the number of possible diagnoses a lot based on the pattern the patient's giving you. But to get to that pattern, you really have to inquire about all the body systems. So you do Socrates for the joint pain perhaps that they're having, but then you really have to go through a thorough review of systems and ask, are you having skin problems, eye problems, fever, fatigue, weight loss, chest pain, difficulty breathing, nausea, vomiting, difficulty swallowing, constipation, diarrhea, blood in your urine, difficulty urinating, pain when you urinate. And all of these things, you just want to go down the body and ask them, because it really will help you define some of these more difficult conditions to diagnose. All right. So continuing on, sorry to linger so long over the A, but really you can see there's a lot there. And I really wanted to emphasize again that review of systems. Timing. So this is pretty easy. Frequency. Is it happening, once a month? Or it happened a couple times in your life? Or is it occurring every day? Or is it occurring constantly? So this is going to matter a lot to the patient. And again, it's more characteristic of some diseases than others. Gout is an infrequent problem for most people. It's bad, but it's infrequent. So they may not know they have gout. They may just know that they get really bad joint pain in one joint every so often. And this frequency will help you show them what the problem is. Periodicity. So, when is it occurring? So when it occurs, is it always occurring in the morning? Is it occurring at night? Is it occurring with use? So obviously osteoarthritis and even some traumatic stuff is worse with use of the area. We already mentioned morning stiffness with rheumatoid arthritis or inflammatory arthritis. Nighttime symptoms. We mentioned the bone pain with bony tumors, or even just if it's something benign like growing pains in a child, that bone pain will be worst at night and deep and penetrating. And then how long? When it occurs, how long is it sticking around for? Is it hours, days, weeks, months, years? Hours, of course, something traumatic, although those things can linger for, of course, weeks and months. Days, gout, septic arthritis, those two can look a lot like each other. You have to really get a good history to figure out, am I dealing with gout or am I dealing with septic arthritis? Weeks, again, we talked about, rheumatoid arthritis stretching into weeks, but obviously a bad ankle sprain will last weeks. And then, months and years, the more chronic conditions. You want to get the timing down really well. You guys can do that. That's pretty simple. Exacerbating factors. We talked about some of these already. Osteoarthritis worsens as the day goes on. I'm not too bad in the morning, but after a full day's work, boy, my joints are killing me. That kind of thing. Of course, muscle pain and fracture pain particularly, any use or pressure is going to really bring on that sharp pain and limit them. And then we talked about the morning stiffness with rheumatoid arthritis already. Severity. Of course, you always want to get severity. That 1 to 10 scale, if 1 is if 10 is the worst pain you've ever had in your entire life and 1 is very little pain, give me a number 1 to 10 that describes your pain. Some things to be aware of is, a partial tear of a connective tissue or a muscle can feel worse and be more painful than a complete tear. So rotator cuff injuries are that way in the shoulder, where a partial tear is way more painful, requires less intensive treatment usually, but way more painful than a complete tear of one of those muscles. A sprain, bad ankle sprain at the time can hurt worse than a fracture sometimes. And it's just the sprain gets better and the fracture doesn't, which is what leads you to know that it's a fracture. Or just in children in general, I guess I don't do a lot of pediatrics with you guys because I want you to get the basics first, but something really to think about in pediatrics when it comes to an injury, a traumatic injury. In peds, the bones are so soft that a fracture is actually way more common than a sprain because the tendons and ligaments tend to be stronger than the bone. And so rather than partially tearing a tendon or a ligament, you end up breaking the bone much more frequently in children. And so you have to always be alert for fracture in children when musculoskeletal injury has occurred, because it's much more common with their softer bones when they're young. And don't just get the severity of the pain, but get the severity of other symptoms as well. How severe is the stiffness? How severe is the swelling? How severe is the rash? All of these things, as you get symptoms from them, do grade their severity. And then this is a really important one. Just like I said, the review of systems and getting all the associated symptoms is super important with musculoskeletal history. So is assessing function. It tells you a lot about how you need to help them, what you need to do to help, how intense your help needs to be. This can cause a lot of problems with their work and their ability to earn a living. When they have these things going on, I had a guy who was a mechanic who developed rheumatoid arthritis, and we were trying to help him, but it was taking a long time, and he was missing work and ultimately got fired because he could not go to work. In spite of our writing letters on his behalf and treating him really intensively, he couldn't function for weeks, and he wasn't able to keep his job. So all of this stuff matters a lot in people's lives. Specifically, you do want to ask about weakness. And it could be, again, that the pain limits them from using the joint, so they appear weak. You want to know, is that weakness actual and real, or is it just perceived by them? That's something you can define on exam as well. Locking. Does the joint lock on them? Typically, a classic example would be if you get a meniscus tear of your knee and a flap of cartilage gets stuck up in the joint as you go to extend your knee, and you just can't complete the full range of motion. Now, usually the good news is you can unlock that by moving your knee around in different directions. The flap goes back down and you can resume full range of motion. So that's what locking is. That's an important symptom to get from people when they have joint complaints. Triggering is another one. The classic example on this one is that, a trigger finger, where someone goes to extend their finger and they can't quite do it the whole way, and then if they push on it, it kind of pops and they're able to fully extend it. That's because there's a nodule, that's getting stuck in the tendon sheath when they go to extend their finger. And there are different strategies you can go for with that, but that tends to be associated with arthritis, like osteoarthritis. And then giving way. And again, the example I always think of is the person who has a knee injury, and they don't think it's that bad. It is painful, it's swollen for a couple of days, but now they're able to walk on it. But it keeps collapsing, it keeps giving way, and they keep falling or stumbling because of it. And that would be typical of somebody who tears their anterior cruciate ligament or something like that. So you'll want to ask about these specific functional things, but just also ask about their life in general. How are you functioning with regard to your activities of daily living resulting from this problem? All right, so to summarize the whole history, just really quickly here, because I don't want to go further with it. We've done a lot. Get the nature and duration of the pain, Socrates. Plus, again, I said, because you want to ask about these other systems, you want to ask about function, you want to ask about swelling and stiffness and other inflammatory signs, but really get a good thorough history using Socrates. And then when you get to the function, really specify, what is going on in their life with respect to this problem. Ask about weakness and locking. And then, boy, really do get that thorough history of the extra-articular symptoms. Ask about the other systems and see what else is involved. Okay. So, you guys know it's not just about the history of the presenting complaint. We also need to get some other history about what's gone on before. Not relevant to this current episode, but what's gone on in previous time. So, the past medical history. Of course, you want to know about prior musculoskeletal problems. They may be related, they may be unrelated, but you do want to know. What problems have they had similar to this in the past? Like I said, the person with gout, unless it's their first episode, typically has had a number of episodes. Fractures and trauma in the past could generate musculoskeletal problems down the road. You know, as the bone heals, maybe it doesn't heal real well. Maybe they have arthritis in an area of injury. Maybe they have a vitamin D deficiency and they've had numerous fractures in the course of their life. And so maybe this injury is a fracture indeed and not just a soft tissue injury. And then do they have a history of other inflammatory conditions? You know, when you have an autoimmune type condition, it's not rare to have more than one. So, you know, you think about when they've had problems. So if they're complaining of Raynaud's syndrome, you want to ask them about, you know, prior joint inflammation in the past. Boy, if they have hepatitis, hepatitis B is a good example. Hepatitis C too, C also is a good example where you have an inflammatory condition of the liver caused by an infection that can generate at times arthritis and even vasculitis. So knowing what else is going on, I'm blanking on examples right now for whatever reason. But you know, a good example is somebody with, say, autoimmune type diabetes, say type 1, who then gets autoimmune thyroid disease. Now, those are with endocrine tissues, not musculoskeletal tissues, but similar things can happen with the joints and bones and muscles. So other inflammatory conditions in their past is something you want to make note of. All right, comorbid conditions. Obesity is, no pun intended, a large problem because it puts a lot of extra stress on the joints. So those people are much more likely to have joint problems because of the stress placed on the joints by the excess weight. So you want to know about that stuff. Diabetes, you know, as they get diabetic neuropathy in the feet, they can end up with what's called a Charcot joint, where the joint in the ankle has basically been destroyed by their inability to manage walking normally because they've lost sensation in the feet. And it's a bad problem. So you do want to know about their other medical problems, even if they aren't musculoskeletal problems. And then even things like, oh, I have asthma, doc. I had asthma for a long time. So you want to ask them, well, have you been on steroids a lot for that? Why would I want to know that? Well, you're much more likely to get osteoporosis in later life if you've had a lot of steroid use when you're young. You know, or the patient who has rheumatoid arthritis and who's been intermittently on steroids. Again, you got to worry much more in later life about them getting things like osteoporosis from it. So always ask about steroid use, which leads into the medication history. So you want to know what they're taking for their symptoms, if is it helping them or not, what resolved prior episodes, that kind of thing. You know, so how was the disease controlled in the past, especially if it's rheumatoid arthritis, they were in control, but they're out of control, things like that. You want to know, well, what worked before? What have you tried before that didn't work? So that when we select the medication, we'll be doing a better job of picking something that will work for you. And of course, adverse reactions. You know, you guys always think about allergies to medications when you ask about the medication history, and that's good. You should, but truly what we ought to be asking about, not as allergies, but adverse reactions. Allergies is an example of an adverse reaction, but it's not the only bad thing that happens from taking medicine, right? You can get other side effects that are not allergies, but are important and need to be considered. So, you know, as an example, I have this chart, again, from McLeod's. You can notice the theme that McLeod's is a good resource for this. But, you know, again, we mentioned steroids with the osteoporosis. We didn't mention that you can get steroid myopathy, you know, proximal muscle weakness from, you know, a course of high-dose steroids could be due to the steroids. Or osteonecrosis, infection because you lower your immune system, especially intra-articular steroids. If you get a steroid injection in a knee, and there's already some bacteria in there, it's going to blow up like a balloon, and the infection is going to get much worse because you've impaired the immune system locally there. Statins, you guys know about the muscle symptoms, and most of it is pain, not myositis. I've seen statin myositis, and it's really bad, but it's rare. Mostly it's just pain, and that pain is not associated with inflammation. It's going to hurt the patient. You just want to reduce the dose of statin usually. Angiotensin converting enzyme inhibitors can cause some of those things, myalgia, arthralgia. You can get a positive anti-nuclear antibody from that, and why would we worry about that? Well, is that from lupus, or is it from, or some other, rheumatologic condition, or is it from their medicine? But you have to think about it. Anti-epileptic drugs cause a lot of problems, not just with the musculoskeletal system, but certainly arthralgia, osteomalacia, bony problems. Excuse me. Immunosuppressants because of the possibility of infection in the joints or connective tissues. And then lastly, quinolones. We're really quick to put people on fluoroquinolones for infections, especially the upper respiratory system, especially ciprofloxacin for a urinary tract infection. But they really do cause significant problems with the musculoskeletal system. You can even get tendinopathy or tendon rupture from these, and that's been pretty well documented over a long period of time now. So be careful with it. That's why we don't give them to kids, because of the effects on the musculoskeletal system, but it can also affect adults. Okay. Family history. This is pretty significant because when it comes to inflammatory conditions, there will often be some kind of inflammatory condition in a first-degree relative. Doesn't have to be the same thing in the patient as it is in their relative, but what you're getting is this grouping of autoimmune conditions. So if they have a relative with rheumatoid arthritis, they're much more likely to have an inflammatory arthritis of some kind than if they didn't have a relative with that problem. Also, just things like osteoarthritis can run in families. My mom had it, my grandmother had it, that kind of thing. Osteoporosis, some people are more prone to it than others, can run in families. And definitely gout. Why? Because, gout is all about the metabolism of uric acid, and you may have inherited those genes that dictate uric acid metabolism from your family. So you want to make sure you get a history of those things and anything else going on. Social history, really important. You want to know what their work is. I mentioned my guy with rheumatoid arthritis that had trouble with his work as a mechanic. One, the condition could be affecting work. So how is it affecting their work? Are there work activities that have contributed to the problem? So maybe it's not just that their condition is keeping them from working well. Maybe it's the work that's caused the condition. You think of repetitive use type injuries. People who type for a living, who get carpal tunnel syndrome. People who are on their feet all day long as nurses in the hospital for decades, who end up with arthritis in the feet and ankles and knees, that kind of thing. So think about how the work activities may have contributed to the problem. Do they, what is their life like? Are they really athletic? Are they doing really intensive athletic training? Is that the source of their injury? Is it a repetitive use injury or trauma due to that? I've seen people with rhabdomyolysis, where the muscles break down and get destroyed from intense exertion. I've seen people after, their first really intense CrossFit workout get that, or after running a marathon, where it really does damage their kidneys and things. They get myoglobinuria because of the muscle breakdown. So ask about intense athletic activity, and just in general, what is their life like? What do they do every day? They may not do that much, and that is also a symptom of badness. If their problem is so bad they don't do very much, it's a really bad problem. It may be that you think, oh, well, they're not very active, so it's hard to gauge how this is affecting them. Well, ask yourself, is the reason they're not very active the pain and suffering they're experiencing? So get how they're able to do their activities of daily living, like cooking, cleaning, getting dressed, bathing, all this stuff. Okay. Nutrition matters, of course, with everything. Our bodies run on fuel. We want good fuel, not bad fuel. But in certain parts of the globe, your nutrition may be more problematic than others. You look at the prevalence of vitamin D deficiency, say, in this region being very high, in spite of our abundant sunlight. That's a problem for the musculoskeletal system, right? More frequent fractures, less healthy bones, as a result. So get a good nutritional history. Travel history, just you want to get it in general. I mean, there are specific conditions you can pick up in other places. If you've been to Africa and you get dengue, or you've been to another place and you pick up chikungunya fever, they cause a lot of joint pain and inflammation. And you want to know, where have they been? What were they exposed to in that type of situation? And then sexual history. We're going to cover that with you guys in depth in this course. So we'll get to that. I'm not going to say a whole lot now, other than to say that certain sexually transmitted infections do contribute to musculoskeletal problems. So things like gonococcal arthritis, or hepatitis C, which could lead to vasculitis and arthritis. HIV, where it lowers your immune system, you're more likely to get an infection of the joints, these kind of things. So a good sexual history really can matter with this. If you're getting a history that fits more with gonococcal arthritis, and we can talk more about that specific scenario later, you got to get a good sexual history. You want to know what the risk factors are for a sexually transmitted infection that leads to joint and muscle and bone problems. Okay. And what are some examples of where the social history can affect musculoskeletal conditions? So alcohol, of course, they're more likely to hurt themselves. So trauma happens a lot. But gout, definitely. We mentioned that already. Myopathy and rhabdomyolysis we don't think about very often. But it really is bad for your muscles. And even the heart muscle. People can get atrial fibrillation due to a cardiomyopathy from their alcohol use. So it's not good for muscles, for sure, either. It's not good for really anything to drink in excess. And then neuropathy. Again, that's part of the nervous system, which we'll cover later in CS5, but it also is something that can lead to joint damage, right? If you're not taking care of your joints by putting them down with the right amount of pressure on the ground when you walk, you're going to get damage to your feet and ankles and knees. You do want to know about their smoking. Lung cancer can generate bony metastases. I had a patient one time present with really severe bone pain, and she didn't have a single problem with her bone. I mean, there was something evident on x-ray, but what she really had was lung cancer. And it can lead to what's called hypertrophic pulmonary osteoarthropathy there. Smoking also has an interesting relationship with rheumatoid arthritis. Drugs of abuse other than alcohol. Again, trauma, more common when you have those types of risky behaviors. But also you're more likely to get hepatitis B, HIV, hepatitis C, and those, as we just said a few minutes ago, can affect your musculoskeletal system. And then the diet we mentioned briefly, but just to give you a more full picture, obviously we mentioned vitamin D, leading to rickets and osteomalacia when you don't get enough. Scurvy, of course, really affects the connective tissues really, really badly. I've only seen one case ever of scurvy, and I even forget the particulars of what happened with it, but they presented with a really warm, swollen joint. It turns out they had a hemarthrosis. The blood was filling up their joint because they were vitamin C deficient. Anorexia nervosa can lead to osteoporosis. So you're not eating enough in general, certainly not giving enough calcium, and your body's metabolizing its own tissues to get what it needs to live, and so you can end up with bad problems down the road from that. And then, of course, we mentioned obesity. Overeating, too many calories, getting obese can lead to a lot of problems. Osteoarthritis can lead to diabetes mellitus, which then gives you the Charcot arthropathy we talked about. So, wow, that is a big, long lecture on history, but it's good to go through it because, again, you'll be presented with musculoskeletal complaints your whole career, really commonly. It'll happen a lot, probably nearly every day, and you want to be able to get a good history. And what's tricky is a lot of those problems could be just osteoarthritis, and they just need some Panadol or Brofene. But you need to be able to tease out the ones that aren't, that are something more severe. It's bad. I had a gout patient present one time with a bad knee problem when I was a student or resident, and the doctor thought it was gout. And so we gave steroids for the gout. Well, turns out it was an infection. And, the steroids were really, really bad for that infection. So the patient ended up getting admitted to the hospital and operated on and all these things. I know a lot more now about gout, and I probably wouldn't make the same mistake he did. But the point is, we can all be fooled when a more common, less severe problem presents in the same way as a more severe problem requiring immediate action. So you want to be able to get a good history to tease those things out and be aware of them ahead of time. So all that to say, human beings are important. This problem is important because it causes a lot of pain and suffering to them. And it's really common, really, really common. You get a lot of opportunities to help people by addressing their musculoskeletal issues. So please do so with care. If you have questions about anything, of course, you can always go to McLeod's. It has a lot of great information in it. It's not perfect or all-inclusive, but it's really good for you guys at your level. But if you have further questions, you can always email me, of course. My email address is right there, or you can always, of course, come by the office, catch me right before lab, right after lab, any of these kinds of things. So look forward to seeing you guys soon in the lab, and thank you very much.